So, welcome everyone to the InCHIP. What is this? The first InCHIP lecture of the fall? The first InCHIP lecture of the fall. I'm delighted to have the opportunity to be here to introduce Sarah Lynne. Sarah is an associate professor of family, youth, and community sciences at the University of Florida. She was trained as a developmental psychologist and also did postdoctoral work at Johns Hopkins School of Public Health and a policy fellowship through SRCD. In addition to her faculty position, she is co-director of the Connection and Community Initiative at University of Florida, which supports student mental health. Her research focuses on promoting health and well-being and reducing the risk of negative outcomes during adolescence and the transition to adulthood. And across this program of research, she's done many excellent and exciting projects, including looking at the application of prevention science, looking at mental and behavioral health problems, policy and technology's role in prevention, health disparities, and work on puberty. I've had the pleasure of getting to know her over the past couple of years, and now I'm very excited for all of you to get to hear more about her work today. So I will turn it over to you, Sarah.
Thank you so much, Eva. I am really excited to be here and to speak with all of you. Today, the title of my talk is It's Not the Destination, It's the Journey, Ecologically Informed Pathways to Health and Well-Being. And as you heard from my introduction, I'm a developmental psychologist. I'm also a prevention scientist. So what that means is that my primary disciplinary perspective is one of growth and change. I'm motivated and inspired to try to understand how humans are influenced by their context and their interactions with others, but also how they shape their own environment, how all of this evolves over time, and how these dynamic processes lead to health, wellness, or risk behaviors. Pretty simple. But that's part of why I chose the title that I did today, because as a developmentalist, I don't focus necessarily on the destination or the outcome. I don't just look at things like mental health and then we arrive at this destination and we call it a day and move on. For me, it's really about the processes. And the processes change. The context that we live in is changing in a really dynamic way. And so understanding these everyday conditions, the journey that we're all on every day, and how as the world changes around us, we're faced with different sources of support and stress, and how that can lead to changes in our mental health, our well-being, or risk behaviors for young people. So I'm excited to talk about some of my work today. I'm going to be framing it from an ecological perspective, anchored by the goal of understanding some of the underlying mechanisms that lead to wellness and how we leverage that knowledge to improve youth outcomes. So here's probably a fairly familiar model for anybody that does research in human development or actually, ecological theories are things that are spanning a lot of disciplines. So this may look slightly different for some of your disciplines, but this image is one that really tries to illustrate how individuals are embedded within nested layers of context that can influence them, from microsystem levels of interactions with their family, their peers, their teachers, all the way out into some of the macro system levels like government, culture, and some of those systems. Not pictured in this image is the chronos system, which is that change over time, which is a big part of what I'm looking at contextually. So prevention science, you heard a lot about that in my introduction as well. As a developmentalist, when I was first being trained, I was really motivated to try to understand all of those contextual factors and interpersonal factors that impact growth. But ultimately, the reason I was interested in that is because I want to understand how we can leverage that information to best improve the health and wellness of young people, adolescents, and emerging adults. And developmental processes are great in embedding it within prevention science because it can help us identify and target developmental periods at which interventions are going to be their most effective. And this is important given limited resources and funding. It's also helpful to take that ecological or contextual perspective because if we understand the context in which people live, then this can help us understand health inequities and how those arise over time. But it can also help us pinpoint malleable risk and protective factors at multiple levels, which can have a differential impact on the people and the populations that we're trying to serve. So analytic methods. I wanted to add this on here. I am, as I mentioned, a developmental psychologist and a prevention scientist. I do not identify as a methodologist, but I am a high-end user of advanced methods. And part of the reason for this is because if you study human development, the data are very messy. Trying to model change over time, trying to understand individual growth or even patterns of growth within the population, dealing with missing data, all of these challenges that arise as a developmentalist and a prevention scientist are things that led me down the path of learning and executing and really appreciating some of the innovation that's happening in statistical methods right now. So as I go through some of the studies that I've been a part of, you'll notice that I use a lot of methods like latent variable modeling, growth curve models, mixture models, structural equation modeling, and missing data techniques. I've also recently been wondering if I should start adopting the persona of a mixed methods person, because I've actually been executing along with a team of really wonderful colleagues some studies that are using qualitative methods. And we're starting to dabble in looking at methods related to AI, artificial intelligence, which I'll speak a little bit about towards the end. But overall, my primary perspective around the methods that I use is that they're like tools. These are the ways when I have a research question or I have data that I can then look and be, where is the most effective and innovative tool that can help me answer this question right now? And the more tools you have, the better you're able to fit your questions to your to the tools that you have available to you. So that's sort of my view on analytic methods. And we're having a lot of major innovation in methods right now too. There's always new tools being developed, and so I love to partner with folks that do that work. And then they can build amazing things and I can help apply it to the populations I'm trying to work with. Okay, back to that original image of the ecological theory of human development. I'm going to first focus on this most outer layer, the macro system or societal impacts. And one of the areas of my research is really focused on developmental research and policy. And that's where I look at what I see as some of the exosystem or macro system influences that can impact individual outcomes. So things like federal or state policies, school district policies, workplace policies, how all of these sort of outer layers or macro level factors can actually impact young people. So to begin, I want to talk a little bit about enhancing the policy relevance of the work that I do. I know when I was very early on in my training, I used to have a single sentence or so, or I'd even read them at the end of other people's articles that were things like this work has implications for policy, and then they would outline a couple of ideas. And then that would move on. And that still can be very helpful and influential for moving the field forward. But for me to try to have a bigger impact in translating the work that I did to policy decision making, one of the things that I found was really helpful is partnerships. So partnering up with the community stakeholders that are the people who enact these policies at the start of the study, engaging with them in the same way that I would engage with research participants, and also partnering up with policymakers. If you're trying to enact or understand policies, understanding what their priorities are and where their leverage points are can be really helpful. The other thing that's helpful is interdisciplinary teams. I have a very specific perspective that I bring to the table, but the work that I do that impacts policy has always been some of my most diverse research teams, which I really love. So working with epidemiologists, people in education, statisticians, people in public health, criminologists, pediatricians, and folks in medicine, neuroscientists, we can do some really interesting stuff when we leverage the power across all of our disciplines. So that's two of the recommendations I have for just beginning to do policy relevant work. The other side is making use of archival data in the best way possible. A lot of times data is produced in our society just because of the world we live in and how it exists. Sometimes it's national surveys that are put forward by the federal government for some reasons. We have the Youth Risk Behavior Surveillance System survey that's run out of the CDC. I've used quite frequently. There's also, I had a student recently who was working with the civil rights data set. which comes out of the Department of Education. And it looks at indicators related to access and barriers to educational opportunities from early childhood through grade 12. So that's a really interesting archival data if you're interested in school-related policies that impact equitable outcomes in the education system. Also state and regional data. The state of Florida has data that it collects on a regular basis about young people in the state. Some of it's in the Department of Education, some of it's in the Department of Health, but it's all publicly available and taxpayer funded. Other sources of archival data that we can pull from: electronic health records, public social media posts, school district administrative data, which admittedly can be quite messy, in addition to the civil rights data for that matter, juvenile justice data. But these data are out there and it can give us information about what's happening at population levels. And if we can leverage that in a way to understand the things that are happening for example, young people in Florida, I can do science that can really be influential for the policymakers in Florida. Okay, so just a couple of examples of the studies that I've done in this realm. One is an older study where I was looking at the state effects of state medical marijuana laws on adolescent marijuana use. And admittedly, I did this work and there has been a lot of progress moving forward in this domain, particularly looking at things like legalization. But I like to still go over this because I think it's an interesting example of how one can do policy relevant research. And then I'm also going to talk briefly about another study that I did more recently that's looking at links between report cards and child physical abuse. All right, so the medical marijuana laws and adolescent use study was one where we looked at 4 states in particular: Montana, Rhode Island, Michigan, and Delaware. It was a quasi-experimental design, but we used multiple design elements to maximize causal inference in this study. So some of the design elements we used were repeated measures. We had observations that we were using the youth risk, the YRBS. So we had observations in 2003, 2005, 2007, and 2009. And the states that we selected for the study all enacted medical marijuana laws at different points along the continuum. So we were able to replicate our analysis of the impact of the law enactment on adolescent marijuana use over time across these 4 states. So we had replication across site. We also did have a theory of the functional form of the effect, expecting that there may actually be a delay in the impact of adolescent marijuana use from enactment to when other things started happening in the state, availability changed or things like that. And then we, as I mentioned, we had comparison jurisdictions, so we were looking across these 4 states. We used a difference in differences design, and in this study, we actually didn't find any measurable effects of medical marijuana law enactment on adolescent marijuana use. There's a lot of caveats to it. First, these were the states that worked for us for this particular data analysis, but it excluded some states that had medical marijuana laws for much longer periods of time and have now more recently enacted legalization. So like California wasn't part of this analysis. So there were a lot of caveats, but at the same time, this did sort of move the field forward in terms of understanding how we can account for like commonalities within the types of states that were more likely to enact these types of laws and how that might change their population impact or the impact of the laws on the young adult population. Longer term outcomes are always better. Looking at legalization policies and maybe taking a more nuanced view of the medical marijuana laws rather than just enactment of the law, but some of the nuances of how these laws vary across state. Okay, so I'm going to go into the school report card and rates of physical abuse. This was a really interesting study, and the reason that it came even into existence for us is from conversations with a pediatrician. And this is, again, sort of where that power of interdisciplinary teams comes into play for doing policy relevant work. So we had a pediatrician colleague of ours that was talking to us because they knew that, you know, we did things like causal analysis and policy related research, and we worked with young people and we were interested in promoting wellness. And they were like, listen, anecdotally in my clinic, I see an uptick of kids coming in with physical abuse cases after report cards are released, and I think something is going on. Is there any way that you all can sort of establish this statistically? Because anecdotally, I'm seeing it in my clinics, and I think it's important. And so we partnered up with the physician and statisticians and some other teammates, and we looked at some archival data to try to get at this. The main objective of the study was to examine temporal associations between school report card release and incident rates of physical abuse. So we looked at a retrospective review of calls to a state child abuse hotline, and we compared that to school report card release dates across a single academic year. So over the course of that academic year, there was approximately 265 calendar days, which were level 1 units that were nested within 64 counties. 4 counties were excluded because we didn't have report card release dates available for them. The participants were elementary age children between the ages of 5 to 11 years old, for whom the calls were made into the hotline. So what we found in this study was that if the report cards were released on a Monday through Thursday, there was no association with an increased incident of child physical abuse on the day of the report card release or the next day. But there was nearly a 4-fold increase in the incident rate of physical abuse on Saturdays following a Friday report card release. So when report cards, we were like, okay, what is going on here, right? We have a couple of theories. Because of the data, we actually can't establish what's happening causally, right? So our team is really just sort of thinking about what could be going on here. Why is it that it matters on Friday, but not these other days of the week? So some of the theories we came up with were that caregivers may be distracted by other activities, work or caring for other children. They may not have the same amount of time or opportunity to react negatively during the work week. They may also avoid harsher punishments when children have a guaranteed exposure to a mandatory reporter, like a teacher, the following day. And as the days go by, it's almost like a natural cooling off period. So this was some of the reasons that we thought that this might happen. But without even understanding the underlying mechanisms, the effects were there. And there was a really strong policy implication that we could draw from this. So first, the idea that there is a macro level factor that can be manipulated that might impact child abuse was a major contribution of this. We did reach out to, this was all Florida data, so we reached out to the school boards across the state of Florida, and they were already sending report cards home on Mondays through Thursday, and it was really easy, a really easy policy change to just exclude Fridays from report card days. So that one was one where it was a pretty easy study that we put together. It was across multiple disciplines, multiple colleges, and we were able to do something that, you know, has the potential to impact child abuse in the state. Okay, moving to the next level of the ecological model. I've also done a lot of work looking at communities specifically. So I'm going to talk a little bit about a trial that I worked on, which was a prevention trial in the Cherokee Nation. And I'll tell you a little bit more about what the Cherokee Nation is like. But I'm also going to talk about a community partnership that I had in the state of Florida, where we were looking at promoting sexual health and wellness. So for the prevention trial, I'm going to focus on this community level factor related to alcohol use among young people, alcohol sales to youth. So first, just to give you a little background about the Cherokee Nation and the outcome that we were interested in. So alcohol and other drug use has immediate and long-term health implications for young people. Rural youth in general are at an increased risk for alcohol use. And the area that we were looking at, the Cherokee Nation in Oklahoma, encompasses this 14-county jurisdictional service area. It is not a reservation. It has about half of all Cherokee citizens residing there. So approximately 150,000 Cherokee citizens. But it is a multi-ethnic rural community that's comprised primarily of American Indian and white populations. So when we were looking at alcohol sales to youth, one of the things that we were interested in these communities is just where are the different sources of alcohol coming from for young people. And one of the sources is when young people just purchase it directly from a commercial outlet. There were some prior studies that looked at young people's ability to purchase alcohol directly from commercial outlets, but these were all decades old. And so understanding, has this changed and what is this like in these communities was a priority. So for the study, we conducted alcohol purchase attempts at all off-premise alcohol outlets. So between 88 and 125 outlets monthly over the course of 10 months. So we did repeated assessments. The young people that we used who were doing the purchasing were all 21 years old, but had been age panel assessed to appear to be less than 21. And they went in and attempted to purchase alcohol without identification. Across all of these attempts, if we just lump them all together, the young people that were doing the purchasing attempts were able to purchase alcohol about 23% of the time across the attempts. But if we looked at outlet-specific results, approximately 76% of our outlets sold alcohol at least one time to a person who appeared to be under 21 without age identification. And this was really important for our communities when we went back and told them this, because a lot of them were like, oh, we know there's this one outlet and it's the problem outlet and that's like everyone else is fine. But to tell them and come back and say, no, we have data that 3 out of every 4 of your outlets are selling alcohol without identification to young people. That changed the community's approach to how they were going to try to protect their young people from sources of alcohol from commercial outlets. One of our recommendations is that you can sort of reinforce compliance by doing regular compliance checks. That's an effective strategy. So one of the communities that we worked in, they passed a community ordinance that required compliance checks every 3 months as a result of this study. Okay, I'm going to talk about the sexual health promotion in rural Florida. This was also a really fun partnership for me because we worked directly with a community that it was a community organization that we partnered with, and they had identified teen pregnancy as a major problem in their specific area. And looking at our Florida state data, it was a major problem. They were like the highest rate of teen pregnancy in the state at the time that we connected with them. So we were working to identify effective programs and see what would fit for their community. And there was a lot of options available. So we landed on one that the funding agency also had sort of a list of their recommended evidence-based programs that would be supported by the funding. And the community was a part of selecting what that program was. And then part of what we did with this was, okay, then we're gonna have you implement this within your schools with your resources so we can see what happens when communities are scaling up evidence-based interventions outside of our control. And for us as researchers, it was really more about providing the analytic support to show what is happening in the effects of the work that the community is doing. So it was a real partnership that we had with this. Here are some of our materials, the I Make a Difference. We had, look at this, 2019, that was back in the before times, as I like to call it. We all got together in actual person space in the community. This was actually a really fun conference because we had members of the community come out from all of the sectors, people from the police department, clergy people, parents, teachers, business owners, right? Everyone was there. And we were talking about what we were doing in the schools and what we're trying to do to help kids. And we gave them some of our preliminary results. And it was this really great, like, community supported partnership that we had. This is my team, just for fun. I like to show, as you can see, I was pregnant in this picture. That's the human that was in there at that point in time. And my beautiful team of people. I'll just say it is a little bit awkward talking about pregnancy prevention when you're like the most pregnant person up on the stage. But it was fine. Everybody just thought that was like a little bit hilarious in the moment. That was just a coincidence. Okay, so the methods, this was a multi-year longitudinal study of rural middle school youth who received an evidence-based and inclusive comprehensive pregnancy prevention program. We served approximately 3,000 middle school students annually. And again, the team and the community team that we worked with were a big part of implementing this in the schools. We did pivot when the pandemic hit, and we delivered the program electronically and virtually, and so we were still able to deliver even after that happened for a bit. Approximately 48% female, funded by ACF. This is just one of the schools I like to show people so you can get an idea. This is a frontward and backward. Like, I took a picture, I turned around, and I took another picture. So this is the school here with the cute little footprints of their school mascot walking up to the door. And you turn around, and if you look off in the distance, you can just see it's like agricultural fields abound. So that's the communities that we were in. It was, these beautiful farming communities in Florida, very rural. But really, really like a great place to be. And one of my favorite things to do is to get out into the communities that we're serving and see, where are the kids living and what is their space like? I think it really helps as a researcher to see it, even when you're working all over the nation or the globe. This is one of the classrooms that the students received the program in. So it was pretty big. It's not a classroom, it's the cafeteria. They were just having all of them come into the cafeteria. So what did we find? Overall, youth reported that they were less likely to have sex in the next 6 months as a result of the program. This effect was particularly strong for young people who said that they did intend to have sex before the program started. So perfect. Exactly the group of people we would want to be reducing that for. And they also reported knowledge gains in HIV and STI infections, transmissions, and how to prevent pregnancy. Okay, great. Here's our graph. This is all data from the state of Florida, and I'm just going to orient you a little bit. Most of these years we weren't part, but you can see that this particular county had higher rates of teen pregnancies than the state of Florida average. 2016, towards the very end, about 5 years along the back there, you can see was where one of the peaks were. And if you look at the trajectory before that, it's actually somewhat flat. It's kind of going up and down, like 2013, 14 is up a little, 15 is down a little, 16 is up a little, but it's not really doing any major changes. So 2016 was when we started our program, and you can see that there was a big drop in teen birth rates, and that remained relatively steady. After that, we were always trying to kind of bring it down a little bit more and help a little bit further, but that was something that our communities were really happy about. Okay, so we know the program worked overall, but did it work better for some than others? And this I thought was really interesting. We looked at bullying that occurred during the delivery of the program, and we found that across all of our primary outcomes of interest, if students were either bullied themselves or if they witnessed bullying of LGBTQ young people, or bullying, any kind of bias-based bullying related to race, ethnicity, that it actually reduced the effectiveness of the intervention across all of our outcomes. So there was a higher intent to have sex, lower knowledge gains in terms of how to prevent pregnancy, STI transmission, and infection. And I thought this was really important because this is one of the first times that I've ever seen bullying during the implementation of a prevention program. This was a sexual health program, but reducing the effectiveness of that other prevention program. I know there's whole prevention programs around just preventing bullying, and bullying being the main outcome. But I think this was really interesting to me because it provided an opportunity for us to consider for the first time that even folks delivering prevention in other domains, like sexual health or violence prevention, or in all of these other areas, that if there's bullying that's happening within the delivery of the program, that could actually be something that's impacting your program outcomes and should be considered. And of course, what we found was the impact of this was stronger for some subsets of our youth population that witnessed bias-based bullying. Okay, I'm skipping school for a second, but I'm going to come back to it. So I'm going to talk a little bit about some of my work that has focused more specifically on family dynamics. And speaking of bullying, it's a nice transition. So one of the things we were interested in was understanding the role of families in bullying perpetration. So bullying peaks in middle school, typically. And when you look at the research literature on the role of parental monitoring on bullying and perpetration, the results were relatively mixed. There were very few prospective studies that was looking at parenting and bullying relationships over time. And so our study decided to look at bidirectional, longitudinal associations between parenting and bullying that spanned the adolescent decade. So I'll show you the results. So this model does not show all of the paths that we actually estimated. I did not include all of those because this would look like the biggest spaghetti plot ever. But it was a model where we were controlling for the relationship between parental monitoring and bullying that happens sort of concurrently within age. We also controlled for these autoregressive paths. So that sort of within person stability in parental monitoring that happens across age 11 to age 18. There's just some stability in what that looks like. There's also some stability in bullying perpetration, right? So we controlled for the autoregressive paths of bullying and parental monitoring while we were estimating these effects. We controlled for the concurrent correlations between monitoring and bullying within time point. And then we also estimated these cross-lagged paths, right? So bullying perpetration at age 11, predicting parental monitoring at age 12, and vice versa, monitoring at 11, predicting 12. All of this was estimated simultaneously. So when we found the significant effects that we found, these are significant, even accounting for that concurrent correlation and the stability in the autoregressive paths over time. So what we found was that there were two significant paths. One was that if you were perpetrating bullying at like this early entry into adolescence, age 11, that actually predicted a lower perceived parental monitoring at age 12. Okay, so that's one of the paths that we found. The other one is from parental monitoring to bullying. And this was between age 13 and 14, which we are sort of also, this is done by age, but if we place this into the classic sort of adolescent education system, the age 13 to 14 is a very typical transition from middle school to high school time period. So that one we found that higher levels of parental monitoring at age 13 were associated with lower levels of bullying perpetration. Okay, so just to kind of summarize that, I showed you the beautiful picture with all of the lines, not all of them, but a lot of them. So bullying perpetration predicted lower perceived parental monitoring at that earlier point in time. What is going on with that? So one of our hypotheses is that youth may have been encouraged by believing that they can get away with it, that they perpetrated bullying, but nothing happened possibly. So they just perceive lower monitoring. But we did find that effect of monitoring near that transition to high school. So, really trying to illustrate back to families, hey, your role as parents is important in adolescence as well, and monitoring kids, particularly in that transition to high school, could be a really pivotal point. All right, I told you I was going to come back to community schools and families. I'm linking it back up here, though. This was a study that we did where we were looking at adolescent risk and protection profiles for violence perpetration across all three of these domains of context. So we looked at risk and protective factors, and at the individual risk level, we had things like, were you victimized by bullying, either physically, verbally, or cyberbullying, depressed mood, substance use, holding antisocial attitudes. Within families, we had risk and protection assessed. So family substance use, poor family management, conflict, but also parent-child connectedness or pro-social rewards. And then within the school and community, we were looking at things like poor school engagement, neighborhood risk, school belonging, their grades in school, school safety, and religious involvement in the community. So these were the clusters of individual and family and school and community risk and protective factors that we were interested in. And what we were wondering is, are there some like unique clusters of risk and protection that exist in the population? And we had some hypotheses based on prior research. But we were curious what would happen if we had these measured, how are they clustering in a latent framework, and is that then predictive of later violence perpetration? So we found 4 groups, 4 profiles was what characterized our data the best, and these are the profiles that we found. The first is one that one would expect, a low risk and a high protection profile. About 37% of our sample fell into that category, and they had very low odds of violence perpetration. We also found a low risk and low protection profile. So it was a smaller group, but it was interesting because they weren't really high on any of the risk factors. So if one was only serving for risk, for example, these are the kids that would not get flagged because they were low on risk, right? But if you looked at protective factors also, you would notice that these kids were low on those as well. So poor family functioning, low school belonging, low community protection. And these young people actually had similar odds of violence perpetration as the moderate risk or moderate protection group, which is the next group. So that group, which was about 44% of the sample, had elevated odds of violence perpetration compared to that low risk, high protection profile. And then we also had a high risk, low protection profile, which we expected based on previous research, and they had the highest odds of violence perpetration. So for me, what I found really interesting about this was that this emergence of this low risk, low protection profile was something that we weren't expecting as researchers, but has real implications for how we maybe try to find selective subsamples of our population that can benefit from prevention programs. Okay, and then I'm going to move into a study that looked at schools and families specifically. So that was this is again a little bit of an older one, but I like it from a developmental perspective. I think it was really interesting, and it's applying the developmental cascades theory. So this idea of this theory is that individuals have interactions and transactions that occur over time, which have cumulative consequences for development. So it's almost like if you started at the top of this waterfall, every sort of transition or pivot point can set you on to a different path, and you can get back to an original path possibly, right? But this idea of this cumulative consequences for development of things that happen over time was really appealing to me as a developmentalist. It's really difficult to assess though, right? Because number one, you have to have longitudinal data to assess this, which is difficult and time consuming to collect. You have to be able to control for continuity over time and covariance within time, right, to help determine if there's a unique and cumulative cascade effect from one domain to another over time. And so this requires repeat assessment of multiple domains or levels of function over time. And if you happen to have all of that in a data set, you also need to be able to apply some pretty complicated statistical approaches to analyze it. And so that is what we luckily were able to do. This work was informed by the transactional developmental theory that suggests that early family risk factors can predict early onset of disruptive behavior, which predicts problems with peers in the school context, and then that'll affect adolescent outcomes. So that was the main model that was driving why we modeled what we did. The data we used was from the Johns Hopkins Prevention and Intervention Research Center, the JHU PERC data, second generation. And we had information in first grade, third grade, seventh, eighth. This is the theoretical model we were testing. So does oppositional defiant behavior in first grade predict peer rejection in third grade, which would then predict substance use in seventh grade or conduct problems in eighth grade that would then affect high school substance use and later age 21 outcomes. So that's the general theoretical path. But while we were estimating that model, and again, this is not showing all of the things that we assessed, but just to give you an illustration, in first grade, we controlled for peer rejection. And in third grade, we controlled for oppositional defiant behavior. And we did this across the model so that we were controlling for those concurrent correlations. But we were also controlling for those autoregressive pathways as well between first grade peer rejection and third grade peer rejection when we estimated the model. And we were correlating these with the other aspects along the pathway, but this pathway was the thing that we were the most interested in. So those are the data that we used. And let me just tell you what we found. So we looked at trajectories of substance use in high school. And the first, we did find support for the peer rejection pathway. So first grade oppositional defiant behavior was predictive of peer rejection in third grade, which was predictive of substance using peers and conduct problems. And then finally, high school substance use of tobacco and marijuana. And those tobacco and marijuana pathways were linked to age 21 antisocial personality disorders, substance abuse and dependence, criminal records, lower high school graduation, and teen pregnancy. So we were able to substantiate this model. The alcohol use model was a little bit different. The first grade oppositional defiant behavior dropped out of the model, but we did find evidence of a third grade peer rejection leading to substance using peers, conduct problems, and then alcohol use in high school. And alcohol use in high school was linked to antisocial personality disorder, substance abuse, and a criminal record. So the pathways were a little bit different across these two substances. And that's something I always find really interesting too. Okay, so what does this really mean, right, from a prevention perspective? The risk for adolescent substance use and young adult mental health problems or criminal behavior begins in early childhood, right? So if we can do prevention programs that work with young people in elementary school, first grade, third grade, around things like oppositional defiant behavior or peer relationships, that can have a cumulative impact and benefit young people across time. All right, so I'm going to jump into some of my current stuff, my ongoing program of research. So what do we have? I'm really interested in technology and mental health right now, utilizing the potential of intensive longitudinal data. Obviously using all of this to inform future prevention and intervention work, and the beginning to integrate both AI methods and qualitative methods to advance innovation. It's almost like the two extreme ends of statistical methods right now. So, and of course, as I love to do, build collaborations and train the next generation of researchers. So what am I doing right now? One of my big focuses is around young people and mental health. And there's two different studies that I'm running. One is around college student mental health. We've done a lot of focus groups with students who experience health inequities, students like international students, students of color, LGBTQ students, students with disabilities. And we've been working with them to identify what their needs are, the resources that are available, and trying to identify ways that the university can best support them structurally and systemically. I'm also working specifically with a group of gender diverse emerging adults around the impacts of puberty and their experiences of stress and supports. This is one of those studies that, under the current socio-political environment that we're in, is really fascinating because we're seeing big changes in the types of stress and supports available for students. And so this is something where these focus groups are giving us some really rich data on what's working, what do students need, what do these young people need, and how can we leverage the resources we have within our communities to best serve them. I will tell you, one of the groups that we're making big connections with are nonprofit organizations in Florida. And then finally, the other thing that I've been working on is technology and mental health. So rates of mental and behavioral health disorders are increasing among young adolescents. This is also coinciding with increased time spent engaging in social media and other online activities. So there's a narrative and some preliminary evidence that online engagement is spilling over into offline mental health problems or problem behaviors, particularly for females and girls. So one of the limitations of this work so far, though, is that it's primarily cross-sectional, and there's a really heavy focus on time spent online, which is not terribly informative. So what we're doing with this current project is we're utilizing passive digital trace data that tells us about what young people are doing with their phones in real time, as well as ecological momentary assessments to understand some of the potential adaptive and maladaptive pathways linking real-time online engagement to mental health. I want to understand adaptation because I think particularly for some of our subgroups of youth, if you're not seeing support within your family or you're not seeing support within your school community, that there may actually be mental health benefits coming from online support. And so this is something we're really interested in understanding, not just the potential maladaptive pathways, but possibly adaptive ones as well. All right, so my main take-home messages. Young people today are growing, learning, and living in a time characterized by really disruptive change. We've just lived through a pandemic. It's still happening. We're having waves of that hitting us right now, and we're all sort of trying to adapt to that. And technology is really disruptive, and it's changing rapidly. I know as an instructor, just dealing with ChatGPT, I'm like, oh my goodness, what's next? But on the bright side, we as academics are continuously advancing our methods, our analytic tools, and our evidence base to understand some of the developmental pathways, the malleable risk and protective factors, and the prevention programs that can work to address the needs and health inequities of our young people right now. So I'm going to keep doing my partnerships across disciplines and with communities that I wish to serve. And I hope that we all are able to do this to help promote the health and wellness of our young people. Thank you. I want to thank my co-authors and my students and my colleagues and my mentors and the communities and the organizers. And this is now my Emmy Award speech. The funding agencies and of course my lovely family that allows me to do this amazing work.
Thank you so much, Sarah, for this great and exciting presentation today. I really like the way you weaved in a lot of your different work from various points and tied it together in the framework for thinking about how to do research in these populations and with some of these challenging questions. So we now have time to open up for questions. So I will be happy to invite questions from the audience.
I had a question. I'll unmute. I'll put my camera on too so you can see me. I love that you're doing that work that is policy-based, and also you have such strong collaborations with the communities you're working in. I would love to hear, I'm a first-year assistant professor, so I'd love to hear what has been maybe the thing that's helped you most making those connections and being able to build those collaborative partnerships, because I feel like currently it feels a little daunting to start building partnerships like you've done.
Yeah, so I have a couple of things that have worked really well. So some of it is partnerships with collaborators, right, within the academic community. And some of it is partnership with like community folks. So with academics, I had a couple of our junior faculty when they've come have started within their first year or couple of years, just trying to set up like meet and greets with faculty around campus that have some similar, without an agenda. We're not starting a research project. I just noticed we have similar overlap. I'd love to just have a coffee with you and talk about your experiences at UF. And through that, I've met new people. I've built different research teams. I've met folks doing work that we have a great alignment. But it also gives you a chance to find if like you're a group that has a good interpersonal connection, because that to me is also part of it, right? When you are working with a collaborative group, you have to be able to have that ability to be a functional team together. And you can kind of pick up on that when you're working and meeting in these casual settings. For community partnerships, I am fortunate to be at the land grant university for the state of Florida, as you all are. And so there is value in going out into community events. So that's part of how I build the connections that I build. I recently attended a gun violence summit that the city of Gainesville held, and it had people from all over the community, the school board, the state's attorneys and the defense attorney's office, clergy people. It was just there were so many, the police department, like everybody was there, right? But they were there under a common goal. And I could come and talk about my expertise as a prevention scientist and how that applies, right? And then I build connections with people. And, I can talk to a local pastor who says, hey, I'm really interested in like promoting healthy marriages. And I can say, hey, I have a faculty member in my department that does that work. Let me help build a connection. So taking that time to be able to get out into your community just as a citizen and meet people and talk to them and tell them who you are. It's a slow process, but it's well worth it because those are the things that help ensure that you have the relationships you need to build those future partnerships and write grants with them.
Thank you.
Yeah.
I teach a really big class, so I'm really patient at waiting and letting people have time to formulate those questions. So I'm sure there's other questions percolating.
I can ask one. I just turned my camera on. I work in the Yukon Health School of Medicine world and across this campus, and I had a question about your collaborations across different fields. You answered some of that kind of inquiry. How do you translate between different fields, different worlds who use different languages? Because you've been talking to all kinds of folks, economists, doctors. How do you handle that challenge?
That's a great question because it's a big challenge. Right now I'm teaching a graduate level prevention science course, and one of my students comes from a health science background, and we were talking about just the word intervention. And, we provided the definition of intervention from a prevention science perspective. And she was like, that isn't what an intervention is. An intervention is this. And she gave a different definition that was more of a medical model type. And I was like, this is perfect because the language that we use in our disciplines has very specific meaning. And sometimes disciplines use the exact same words, but they have different definitions. And if you're talking to somebody and using the same words, you think that you're communicating the same message, but you might not be. So it is a challenge. One of the ways that I've tried to be really effective is that I have a little bit of training in a lot of these areas. So I've taken some background training in epidemiology, so I understand it's almost like learning foreign languages, right? It's like I understand their language a little bit. I've done a little bit of recently some more background training in things like AI methods, so that I can use the language that they use to try to explain what it is that I'm trying to do or study. And I tend to walk into conversations and just introduce myself by my disciplinary perspective. So that way other people know that it's like, this is the way I'm thinking. This is the terms that I'm using. If I say something that doesn't make sense to you, let me know. And we just kind of try to make it very above board and like, it's okay. We all talk about things differently. But it's hard. First, I try to teach my students the jargon of my field, and then I try to teach them not to use it so that they can talk to actual human beings in the world again.
Thank you.
Yeah.
I think we still have time for a couple more questions if they're out there. Well,
I can ask one more.
Sure.
You spent a lot of methods and data types and analysis. Actually, we're going to meet after this meeting, and I'm a statistician, but I noticed probably one kind of hint at including location in further kind of investigations or analysis, the location of participants or the event, or in other words, the spatial location. Are you planning to play with that?
So I am interested in that. I don't have any expertise in that type of data, but I have a colleague that does work with, she's a geographer. I'm like, okay, now I have to learn that, right? But she knows how to do all of that, like place-based mapping and create those super cool maps where you look at like distributions of, some of them are epidemiological, right? Just like burden of or distributions of the outcomes that you're interested in based on geographical location. And helps you understand the different areas that you're serving and what their needs are. So it's something I'm interested in. I don't have active plans right now, but with some of the technology stuff we're doing, we are going to be able to have data on activity, movement, lack of movement, and things like that, so that we'll have a better idea of, and some of this movement data, just the accelerometer on your phone can give us information about depression, right? Like, are people, did they have a typical level of activity and now it's dropped in an unusual or in a different kind of pattern, right? Or is there activity happening at hours in the day when there shouldn't be, like it's disrupting sleep? And so that's some of the stuff around, like, where are you? What are you doing? How active you are? When is it happening? Some of that we are planning on looking at.
Thank you.
Mm-hmm.
So Sarah, just to piggyback off of that, first, that was an incredible talk, really, really important work. And thank you for coming and presenting today. I was really interested in, well, in a lot of it, but one of the things that you mentioned was passive data trace. And so I think that's related to the point you're making. And I was just wondering, it's new to me, and but I could see where it could be very important in the work that we all do in health behavior. And I was just wondering if you could speak any more about that or the methods that are involved in that.
Yeah, so we're partnering up with a company that has been able to develop an app that works with Androids and iPhones, and they are able to collect data in the same way that some of the big companies do, right? Google, Facebook, whoever, and they can. But now these data can be made available and be used by academics to understand things related to risk and health. And so, so that is, I think, really helpful, because in a lot of ways, we've been wanting to understand this online environment and how that environment might impact our lives, right? Young people's lives, our adult lives, for that matter, right? But when the only way we're able to assess or measure are things like self-report or like how many hours a week or something like that, it can not be the best way to try to assess real engagement with technology. So that is the type of data that this company is able to collect, comes directly from the phones, and it deals with things like, depending on what you're interested in, but like accelerometer, movement, ambient light, apps usage, how much, like which apps are you using, how much time, what is the nature of them, things like that. So we can begin to get a more accurate picture of what it, like the real online behavior looks like for young people.
Very interesting. Thank you for sharing.
Yeah, I'm excited about it. And if anybody's interested in the company, I'm happy to share contact information too. I'm sure they would love to have more people working with them.
That'd be great. Thanks.
Well, we are out of time, but Sarah, thank you again so much for joining us today and telling us about your work. And thank you everyone else for attending. Enjoy the rest of your afternoon.
Thank you, Sarah. Thank you, Eva.